Hello, good afternoon, everyone, or good morning. Can everyone hear me okay?
Yes, we can hear you, Marcy.
Well, I see you have Dr. Gomi on, so why don't we go ahead and get started? Thank you, everyone, for joining our TIC Talk webinar today. This is the last of our 10-session series, which is hard to believe. We are offering nursing contact hours, so make sure to enter your credentials when Mary pulls up that polling question. And the sessions are also recorded and available on our Mountain Pacific website. So you will have the ability to unmute yourself, as I know Dr. Gomi always encourages questions and participation, but when the presentation is going on, if you are not talking, to just please mute yourself to eliminate any background noise. And you can also feel free to enter questions or comments in the chat. And we encourage everyone to use your camera if you do have a camera and you're able to do so. So now I'd like to introduce our speaker, Dr. Reza Gomi. Dr. Gomi holds a BS in computer engineering from Rensselaer Polytechnic Institute, a MSc in biomedical engineering from Johns Hopkins University, and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology such as voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So with that, I will go ahead and turn it over to Dr. Gomi.
Wonderful. Hi, everybody. Let's see, last one today with me for now. I'll be back, don't worry. So we're going to be, I just want to start today with a plug for my colleagues. So Dr. Seiss, the only practicing and board certified addiction psychiatrist in Montana, will be launching our next series, which is perfect timing because that's launching our 3D Project Echo. And for those of you that are not familiar, Project Echo is a national kind of brand, a national sort of program where there's multiple examples of it all over the country. And so we're starting one for our region, and that's really meant to be, it's a community support program where we'll do presentations for clinical providers, for staff, we'll do case presentations. And so he's going to be starting a 10-part series in April, probably likely late April. And that'll kick off that program, but that'll also be another 10-part series. So please tune in and check out Mount Pacific's site for more information about that. That's going to be a nice resource to focus on, excuse me, substance use. And you guys will love Dr. Seiss. He's an outstanding provider. He loves teaching. He still continues to teach residents and fellows nationally. And he's a really good presenter. So definitely tune in for that. And if you like him more than me, you can keep that to yourself. Let's go ahead and get started. So I'm hitting the present button, and then let me share screen, and then hopefully we'll get a little bit of presentation today too. Let's see if this works. No, that's not it. Let me try. Oh, there we go. Did it work? Nice.
Yep, it's on.
Cool. It's working. Okay. So 10th of the series, guys. It's been a marathon, but we made it. This is the last one. The focus of today is going to be really family and caregivers. So we'll do our usual recap, and then we'll jump into some how to communicate with families, how to discuss things with families and caregivers as well. A lot of this is really focused on you as professionals who work in a nursing home setting already, how to bring in resources, how to ask for more support, and then how to help family members when you can actually ask for more and more involvement. No new disclosures since last time. Again, this is just a repeat of our agenda. We've already at the 10th one, and I mentioned, so tune in for next month. We'll be kicking off another 10-part series. So just a review, and I really, for me, repetition helps a lot. It's really about like how to make this memorable, how to make sure we walk away with a few key points here from this series. One of them being the whole trauma-informed care initiative. So trying to inform trauma driven care in everything we do. And each talk we've done over the last about 10, 4 months now, has really attempted to highlight how do we take a topic that we've previously might have even been familiar with, but then inform some trauma-informed care into it. And so the reason we're doing this, we've gone over, is some of it is sort of federal mandates and whatnot, but really what connects to us as humans, which is more important, and ultimately what's going to help with our motivation to remember to do this, is really the empathy piece. Remembering that, just like us, the people we're taking care of have been through certain things, and some of those things may not be the traditional sort of traumas or adverse childhood experiences like we see on the slide, but that they're all important to keep in mind, and they impact everybody's experience and presentation, especially as we age, and especially as we move into an assisted living or a residential facility, skilled nursing, wherever we're living when we're older. Those childhood experiences and that early life impact is going to totally shape how we behave and how we appear to others. We talked about the Lewistown example. We'll be updating this data actually, hopefully. So we're trying to do some more data collection here, but one of our talks was really trying to help everyone feel comfortable doing a quality improvement study where they are at whatever scale with whatever budget, whether that's zero or you have plenty of support. And so tracking little things like how number of patients participating in, like, let's say a community activity, and then working on increasing that over the course of a couple months and seeing what number you can get to. Something, it can be really straightforward. And I'm talking about data collection can be a notepad with check boxes, and doing some really basic stuff there that might seem basic. I mean, it's not. It's all impactful. So being able to do that is really important. So loneliness we talked about. So the focus of that, again, just really bringing emphasis to the fact that sometimes we get lost thinking about medical comorbidities and the usual suspects when it comes to health, such as smoking and dieting and weight loss and things like that. But remember that loneliness is a huge driver of outcomes in nursing homes, and in terms of life expectancy, and also dementia, other types of risk factors. It increases risk of vascular disease, heart disease. So really emphasizing the importance of loneliness. And we went over some methods, especially in the era of being on video and having a lot of things limited in person. So really encouraging people using name tags, making technology as accessible as possible, and as much as possible using video more than audio as much too, so they can have stimulation from both domains. And really encouraging family and caregivers to be creative in terms of connecting with their loved ones. It's obviously better than nothing to call, once a week, but it would be lovely to provide other sources of stimulation, whether that's a letter or a card or really anything else. Dementia, which is really my area of passion overall. We talked about how best, so educating this, and this is a national, really worldwide issue, is right now, most of our patients everywhere are, probably more than half, are undiagnosed or don't have like a clear diagnosis. And so really helping increase education on this piece is big. This helps target treatment to individuals, improves quality of life, helps for future planning, helps people be eligible for research studies. So it can really help. It also helps shift the frame for when you're approaching someone when you know that they have a neurodegenerative disease. So remembering that dementia is an umbrella term. It is really all about function. Every one of us on this call can diagnose dementia, because those criteria, you don't have to know how to read a brain MRI. You just need to know that if there's 2 or more areas of daily functioning impacted, And we know that it's not because, they're just really sick. They have COVID, their sodium is low and they're delirious. Obviously, notwithstanding any medical other issues, this is kind of a slow, progressive, chronic issue, 2 or more areas. They have dementia. The most common so far that we still know is Alzheimer's, although we're starting to recognize that there are quite a few other players here, but really that's the most important one. And being able to have these conversations with people to help them understand what Alzheimer's is, and taking that strengths-based approach so that patients don't necessarily feel hopeless and wanting to give up. There are plenty of things to still be done when you have a diagnosis of dementia. I've been hammering in this normal aging graph because I get a lot of these questions. And really, I want you all to feel comfortable speaking to this with caregivers, loved ones, because you're going to have, and later today, we're going to be talking about approaching caregivers. You're going to get a lot of questions like, oh my God, my mom has dementia. I'm going to get dementia. So we want to be able to speak to that. And part of that is knowing what normal aging is, and that your processing speed, perceptual speed, spatial orientation, that whole the difficulty driving at night, those things do get naturally a little harder when you age, and you'll probably notice it. But should you not be able to do them at all? No, but you might notice a decline, and we want to be able to reassure people that that's normal. If they're still remembering languages and being able to do their math and do the tips on receipts and stuff like that very well, also very reassuring. Those should not change that much with age. We talked about the very, although it doesn't seem rapid, we're at an inflection point historically. This is a major time right now. On April 7th, I believe the FDA will be issuing a decision for the first, what would be the first disease modifying agent approved to treat Alzheimer's disease. So just be prepared. When that is approved, whether it's this one or there's several others in the pipeline, we're going to have 5 to 7 million people in the US, many of which live in residential facilities asking for that medication. And it's going to be something we have to be aware of and have a plan to address, because it's not going to be easily accessed because we just don't have the infrastructure for it. And I'm not talking about rural areas, in Alaska. I'm talking about everywhere. So we want to be careful of that. This slide is tied into that because it's very likely that these newer drugs in dementia will require biomarker confirmation. So it won't be just for anyone that has dementia or even Alzheimer's clinically diagnosed. They will have to have a CSF amyloid beta or a PET scan that is amyloid tracking to know that protein is in their brain before they'll be eligible for that medication. So I'm working with a number of stakeholders to figure out how we're going to accomplish this at scale. But again, these are things just to keep in mind, to be on the horizon. But we're going to be seeing some new drugs that are going to transform the landscape of dementia care very soon. We talked about the importance of diagnosis. So what I just mentioned about new drugs being available, of course, that's going to require diagnosis. But as you all know, working with people, more information you have, the more you're armed with, the better you are at your, being effective at providing care for your patients. And so that's what really gets me motivated. Is I love being able to provide people more information about what's going on with their brain. That's what I love to do. I think about it, if and when I'm in that situation, I want to be able to have as much information as possible. So this is how we do right by those we care for. Pointing out, again, reasons to be optimistic. Big chunk of people out there have vascular dementia or vascular risk factors. That's a hugely preventable thing. We can intervene there. Hearing loss, getting people to wear their hearing aids, alcohol, hypertension, preventing TBIs, treating depression and smoking. All these add up to a potentially modifiable 40% of dementia. So keep that in mind. We're never lacking of tools or things we can be doing to help people. We talked about delirium, right? So delirium, we all see, and we will continue to see. It's a natural part of, unfortunately, the dementia process, and happens a lot. So it's going to be very common. We have people that all of a sudden their attention and awareness is differing. It's waxing and waning throughout the day. They tend to fluctuate. Their thinking is off, like they're all of a sudden a little bit more confused, not knowing where they are, what time it is. They might be having visual hallucinations, just that kind of thinking is disturbed suddenly. We don't have a good other explanation like, they also have Lewy body dementia or Parkinson's, and they tend to have visual hallucinations with a certain medication. You know, we want to be careful. Obviously, there are other reasons, but if you fall into that bucket, delirium becomes a high concern. And what do we do? That's a medical emergency. We want to get that UTOX. We want to really figure out, is their sodium low? Are they dehydrated? We got to kind of go down that checklist and figure out why. And usually when we fix that problem, they get better pretty quickly. And keeping in mind, the longer they have the delirium, the longer it takes to get better. So if we're good and we catch it and we fix it within a day or two, they get better very quickly. And having that addressed within those first couple weeks has a huge impact on how they do, on how fast it takes for them to get better. And you can see what a high percentage of long-term care facility patients have dementia, 68%. So this is super relevant here. Ways to hopefully help prevent delirium. So obviously if somebody gets infected or has a sickness, that may be difficult to prevent, but someone who's sort of teetering on the edge with dementia or with other just impacts to their brain, they may always kind of be a little bit on that edge of delirium. So how to help? Sleep cycle, being regulated, sleeping at night, curtains open during the day, getting plenty of light, having access to a clock on the wall, a whiteboard, reminding them what day it is, what time it is, what they're doing, what their medications are. Again, doesn't matter where you are, how old you are, how impaired or non-functional, we always want to provide information as much as possible to patients and empower them, right? And so that will help their brain the more we reorient them. And that doesn't mean you have to stand there and tell them what day it is over and over again, but we want to give those cues in their environment. We talked a little bit about how to do things. So all of us, again, can detect delirium and see that. That's when we get our providers, our nursing staff involved, and we say, hey, I'm worried about delirium. What do you think? Like, start the conversation. We're all on a team here. Again, these were super important points. So I want to point out, avoiding physical restraints, bed alarms. It's tempting to use things like, different various forms of restraints. And yes, we've talked about this. I know I've beaten this really pretty well. They are necessary at times, but it turns out over the years when we've studied this, that really a surprising majority of restraints can be avoided through various approaches. So challenging ourselves to, the more we avoid those, the less likely patients are to suffer delirium, providing that reorientation. Avoiding PRN medications with our patients in residential facilities is best to actually have patients as much as possible on scheduled medications. Of course, PRN Tylenol is one thing, but anything that's sedating or otherwise altering psychotropics, better to avoid those PRNs. It just, patients do better when it's scheduled. And so again, those are the kinds of things to keep in mind. You don't have to be this is something to advocate for your patients. I've had advocates, for example, at one of the nursing homes I help out with, some of whom are on the call today, saw a patient and somehow I kind of slipped up and wrote for a PRN, and they were quick to remind me, and we took care of that. We took the PRN off. So that was really good teamwork. I think it was a combination of the social worker and then the pharmacist who picked up on it. So that was super helpful. So again, teamwork really helps call these things out. So behavioral emergency, with the caveat that behavior is taken to mean something very, very specific here. So imminent threat of harm to themselves or others. And again, behavior is all in the eye of the beholder. So, right, keeping in mind that certain behavior is not necessarily abnormal. If I put you in restraints and stick you someplace that's not your own house, right now, you might have some quote unquote behavior, right? So we want to be careful of, are we doing everything to help this person feel comfortable at home, safe, respected? And despite our best efforts, at times these emergencies do come up. And what do? We got to approach that person same way. Ideally one person. We want to have a sort of calm approach. We want to not overwhelm them with a ton of people all of a sudden. Unless it's truly, we're talking about on the risk of there being physical harm to someone. We want to validate how they feel. And then really, again, there's almost always solutions. I care for patients at our state nursing care center in Montana, and they take care of, some of the sickest patients I've seen. these are patients that have some really, really unfortunate and disabling diseases. And, sometimes, I'm just truly impressed how often with some pretty, sometimes very agitated people are, again, out of their control, and really not really amenable to having a discussion, how well they avoid restraints and how well they avoid escalation. It's impressive. So big shout out to Lewistown, the Montana Mental Health Care Nursing Care Center. They do an outstanding job, and those are just examples we can all learn from. But when I see that they can do it, I'm like, okay, we can all do this. Please, me, jump in if you have any questions or any comments. So how to prevent, a lot of this is really just in anticipation. So from working in emergency rooms, I can tell you substance use, no big surprise. That's the biggest predictor of somebody being an imminent threat to themselves or others in an acute care setting or in a long-term care setting. So if they're withdrawing, if they're using substances, that's going to be a huge trigger. Because I'll tell you right now, if I go out right now and use a bunch of cannabis or meth or whatever it might be, I'm probably going to act not safely. So this is something we're all susceptible to. This is not, again, these are substances that can do it to anybody. So anticipating that, knowing if there's that substance history will allow you to prepare. So if I know somebody is a heavy drinker and they're coming in, I just, I jump the gun and I give them some things that are going to help them. If I know they've been using opiates, I give them things that are going to help them feel calmer, because that's going to, I can kind of anticipate. Dementia, delirium, also a big predictor. Again, these are things that are out of their control. There are some things that are not going to be able to really be talked through. So you can see most of these are neurodegenerative or brain injury related in terms of behavior. We do have, all of us probably have had patients with a severe TBI that we care for that have had long lasting impacts on, anger and irritability, and that can be challenging. We talked about this a little bit. So we move on to psychopharmacology, which we challenged, which we chatted about. So, again, reminding people, we're all a team. This is super important. We'll talk about this with the caregiver piece a little later, but we brought up the Beers criteria. This is something that's updated every 2-3 years or so. The Geriatric Society nationally keeps this, kind of owns this, but it's really helpful. It kind of throws out what are medications in the ideal world that would be avoided. Knowing that many times we need these for our patients, but it's very, very helpful to know this. And that way, again, you as a any of you that are on this call that are not providers, still helpful to know there's some core medications. I just had another family just message me and say, hey, I started taking, it was ZQuil. And so even despite because this is going to happen. I mean, we can't expect people to know all this, but despite all my counseling to avoid Benadryl containing products, ZQuil says diphenhydramine. That doesn't sound like Benadryl. I can take that. And so they take that. And what does that do? It leads to confusion, leads to higher delirium risk, things like that. So this was in somebody with Alzheimer's. So just keeping that in mind, because you might have a family member that's like, oh, I'm just going to drop off some Benadryl for grandma, helps her sleep at night. So knowing that, it can help you advocate. There are safer alternatives. There's always safer alternatives. So just keep that in mind. I threw out a colleague of mine, Karen Duong, who works with us. She's a geriatric psychiatrist who sees patients in Montana and Wyoming with us, who made this really nice tool sponsored by the VA. VA is a wonderful kind of program and center that nationally they have really impressive resources. And a lot of them, what's cool is they're available to everyone. They have a really impressive suite of apps on the App Store. You can look for various VA apps on their website, and they're free. And you don't have to be a veteran to use them. They're really, really, really well done. There's a CBTI, cognitive behavioral therapy for insomnia coach app. There's a PTSD coach app. I mean, I think there's like 20, 25 apps, and they're great. Really good content, totally free. So it's like, take advantage of it. That's easy to use. Just look on the VA website, look under their app list, and you can download it on your Android or iOS device. So this was one of the resources they worked on. Just a quick little pocket guide. You can print this out, keep in your pocket, but just sort of things to both avoid, but also not. And again, just advocating and say, hey, I noticed, this patient, she's actually been on, maybe venlafaxine or some other medication that's not ideal for 30 years. Well, 30 years ago, it wasn't a big deal because that person was, 50. Now they're 80 and things change. So just kind of always checking in about that is very helpful. And we need advocacy to do that from everybody. The last time we talked about cognitive behavioral therapy, so with trauma-informed care. And so CBT is probably new to some of us, and then obviously some of us do CBT on a regular basis. The important thing is here, we try to touch on some CBT topics that are accessible to all of us. So trauma-focused CBT was sort of the most relevant in terms of having that trauma-informed care. And so let me open up the chat too while we're talking. Anyone that has a question, just please throw it in chat.
There is one question.
Brian, I'm just seeing your message now.
Can you see it?
Prevention mentioned issuing threats such as calling the police or involuntary command. Could that potentially happen? Yes, exactly. Sorry, Brian, if I wasn't clear, that those were things to avoid. So things to avoid, like, so we're not threatening people because that can. And of course, sometimes you may need to call for help, but you can do that sort of quietly just to hopefully prevent escalation. So again, CBT is something where it's the more you stick to sort of the manual. So there's different flavors of CBT, if you will. They all have their own manual and kind of approach. And so the more you stick to that, the more successful it is, based on our study. So fidelity, when we're talking about, so how accurately you follow the manual is a big driver of outcome. So you can start with a just very brief CBT intervention and just follow that and learn that and memorize it and follow that over and over again. That can be very helpful. We can also, when we have it available, have people do a 12 to 20 week session formal CBT program with the therapist. But where we are in a lot of places where it's not possible, we went over some ways last time to inject CBT into our practice that might just be brief interventions here and there. And you can see down here, CBT covers a bunch of different areas, right? So education, we talk about relaxation, regulating your affect, how to actually help when you're feeling really, dysregulated or feeling really, really sad, how to help actually give some power to that person to regulate them, cognitive processing, trauma narration. So you can see there's a bunch of different things that fit under this umbrella. Correcting cognitive errors. This is something that comes in super handy and we can do every day because I make these errors myself. So, it's helpful to actually practice on yourself and then, you remembered how to do it with the patient. I correct these actually every time I work with a colleague of mine here, Casey. I have to correct her cognitive errors because they seem to come up all the time. What was one of them, Casey, we talked about last time? She's not, she refuses to talk publicly. So Casey is a good case study. She has a fear of public speaking. And so within that fear, right, it's a good example. There are some cognitive errors being made, such as maybe everybody will laugh at me. Maybe I'll trip up and, say something wrong. So some of the cognitive errors are, those things obviously may happen, but a lot of us think this way and we kind of help fix that cognitive error of, hey, well, let's actually think about what the risk of that is. And if it happened, what is the chances, everyone's going to actually like right now just erupt in laughter and, and do those things. So sometimes it's cognitive errors driving that. One of these days, the next series I do, Casey, we'll get you to talk. So I'm slowly working on it. So again, 3 cognitive errors down here we highlighted that we can all watch out for. Treating feelings as facts, like because I feel nervous or confident, you assume that then means there is a danger or not, right? Not the case. And again, you want to sit down and patiently just kind of go through that with the person and really inspect what they're thinking, what those thoughts are. Picturing the worst. And so the more you picture something like the bad thing happening, right, you're going to then over-calculate the chances of that thing happening. Again, we all do this. I do this myself. You can ask my wife. I'm very annoying about certain things because I think about, the negative and then I way overestimate. Intolerance of risk, so control is a big thing, especially for, when you think about some of the control we take away from patients by unfortunately having them live in facilities. This is going to come up, right? There's going to be other areas we have to provide control for, because that's only fair. It's only natural as a human. You want control. So if they don't have full independence where they are, we got to find ways to give them independence and help them focus on that. And there's always ways, there's always something to be independent with. So let's jump into the first poll, and then we'll spend the rest of the time talking about caregivers and families. Do you feel comfortable communicating with family and caregivers, answering their questions, providing guidance? Is this something you look forward to? You don't? Is it something that makes you nervous? Go ahead and answer this, please. And I appreciate thus far in this series, I feel like people in general have given very honest answers. Give about a few more seconds for people to submit their answers. Do a little stretch, wake up. We're hitting the halfway mark. We're probably, either standing or sitting, getting a little bit tired. Look at the results, and then we'll look at this next poll, and then this will kind of inform the rest of our talk. Nice, 91% said yes. So we're gonna figure out how to help those 9%. Maybe we can boost them a little bit with the rest of today's talk to kind of push them into that yes category. So wonderful. If we can throw up here we go, I'll share these results. And then we can kind of throw up that next one. Oops. While we do that, go ahead and put that in the chat section. I'm going to stop the share just for a second. But while you guys answer that, please put in chat what you're thinking while I make an adjustment. Are people writing in chat? Let me see. There we go. Okay. There we go. I'm seeing some stuff come in. Good, good, good. Keep it coming. Okay. Chat no go. Where are you, chat window? Let me pull it back up. Chat. There we go. Come on, everyone. Let's get warmed up. Put in some comments. So I'd like to provide reassurance. So reassurance can take, a few different things. Joby, or if you're able to, I know some people don't have access actually to a microphone, but anyone able to if you're able to expand on that in terms of reassurance, let me know. Andy says, reassure families that changes in dementia are due to disease process, not because their loved one doesn't. So that's super important. How hard is it not to take it personally, right? When the loved one or someone you've known your whole life, all of a sudden is maybe acting a little bit differently, or doesn't remember certain details, like doesn't remember your birthday. That can be really, really hard to not take personally. So that's super important reassurance. So great. Those that don't think they will qualify for service, to apply anyways. Absolutely. Really encourage, right? We live, where we all know, there are certain barriers to things, and we got to kind of, sometimes the more persistent get rewarded, right? So we want to stay persistent, and sometimes it's hard to know, even when the rules and the criteria are actually out there, sometimes you'll qualify anyways. Joanne, let them know they aren't alone. Others experience it. Yep. That empathy is really, this is where we really strive to have empathy. Reassurance from disease process. Advise of support group scenario, wonderful. Support groups are invaluable to have. Watching I'm Here, Glenn Campbell movie, nice. Those are good recommendations. So that exactly, use these resources, right? You don't have to necessarily sit and spend and have a lot of time. You might have them, watch a movie or watch another a video or some other type of educational content. Talk to families, provide reassurance and discuss changes that are occurring due to dementia. Great. Wonderful. Yeah, Alzheimer's site gives lots of help to support explanations. Wonderful. Casey says help with new approaches and responses to a loved one. Yes, so knowing how to, this is a core part of what I do in dementia clinic, right? Is now the diagnosis happens, the things are changing. And so they'll say, oh, so should I keep correcting them when they insist that, they just drove, they just went for a drive? And yeah, and then now the answer is different, right? Because that person maybe has a neurodegenerative process. So maybe it's more appropriate to not correct them. So it's a lot of it is reassurance and how to approach people when they have memory loss. Yep. And self-care, big time for caregivers, right? Caregiver burnout is the biggest predictor for how that person with dementia is going to do. So we definitely don't want caregiver burnout. So yep, advising us. So these are great. Keep it coming. We'll continue on, but please keep these comments coming. So here's a comment from a patient. This is all great, but my doctor spent 7 minutes with me and has no idea about any of these things. And replace doctor with anybody, right? My social worker, my whatever. Sometimes people interpret, right? Time goes by quickly. And when you have a lot of information coming, it can feel like you don't get the chance to really ask questions or really advocate for yourself. So keep that in mind. Perspectives vary, right? So when you're talking to a caregiver or patient, sometimes it feels like a fire hose of information. So we want to be repetitive. We want to offer things in writing and reminders in order to kind of help relieve some of this. So finding resources, right? At the family level. So even if you're taking care of somebody that is now in a long-term care facility, they probably, in most cases, they have somebody involved, some kind of a family, friend, loved one, and that person should still be advocating for their loved one. That doesn't stop. Yes, I've had a wonderful experience. The vast majority of facilities I work with are wonderful places I would live myself or have family members live. But really, you want to keep that person involved. You want them to be there because as things change, as health declines, you want them to be there. So recognizing the need early is critical. We want to, I really push people to consider what's appropriate, whether it's assisted living, long-term care, skilled nursing, that kind of whatever makes sense. I push them to consider it before they think they need it, because by the time you think you need it, it's going to be a little too late. And then it takes too much time to get in. And then there's stress and caregiver burnout. So a lot of what I do is I give people sort of that permission of, you know what, it's okay to actually say you need it now and get the ball rolling. So recognizing the needs of the individuals, identify their strengths. That will help you identify, and this is all things you're going to be counseling towards the caregiver, loved one of the patient. Like, what are the things they need? Some people need more help toileting and showering. Some people need more cognitive help. Some people are physically intact. So really identifying that, having them write that down, super helpful. Encourage caregivers and family members to write this down. So encourage them, because sometimes it really makes it real, makes them realize it when they write it down, they look at it and they say, wow, my loved one is no longer able to do X, Y, Z. And it really kind of puts a different perspective on it. So this is sort of part of that needs assessment when I'm talking about writing it down, right? So I encourage caregivers, and these are some frameworks to think about, but just super basic, just jot this down on a notepad, and I have the patient and or the caregiver, to the extent possible, have obviously the patient involved, but think about not just their medical, what are diagnosis medications, but social, what's important to them? What do they need access to? If they're going to move somewhere or be somewhere, what is it that really, really gives them that little bit of a joy in life? So that's going to be important. Making sure the legal stuff is in place. I'm constantly advising my patients, hey, now's the time. If it hasn't been done, now's the time. Do not wait. You don't want to wait for a situation where your loved one is incapacitated, right? That's a lot of people's worst fears. Transportation. So even if they're in a long-term care facility, how can we improve and increase their independence? How can we get them access to outside resources. Maybe we have some version of a access van, Alzheimer's Association, various associations that can kind of help with transportation, but we can get people to be participant, like going to the bingo at the local church. That can be that's just like a hugely uplifting experience. So we want to help people do that. Housing, of course, not as relevant here if they're, in a stable housing with a care facility. Insurance, food, spiritual, lots of things to consider here, right? Again, coming back to this, right? So develop that plan. You want to create accountability. Yes, we're staff and we take care of people, so we're all accountable. I have my, assessment plan. I keep track of things in my note, and I'll jot down not just medications, not just medical, but I'll jot down, did your cousin do the thing they said they were going to do to help you? And I'll follow up on this stuff. So we want to create accountability, because that also, once that accountability, when I'm asking that question and one of us is asking that, all of a sudden that person realizes, oh, I have responsibility. This is important. Hey, did that loved one, they said they were going to, write you a letter once a month. I follow up and I make sure they're doing that. So whatever it might be, whatever's appropriate. But if all of us here are creating that accountability, you get better results. So it's not just for the patient, it's not just prescribing. And then reaching out, of course. So encouraging that reaching out by family members. So touching on, just repeating again, maximizing resources. What's important? What's important for that person? What's really necessary? What's nice to have? Looking for resources in your area. Be very open-minded with that. There's no matter where we are, there's always some kind of resources and volunteers that'll help. Keep in mind, the majority of caregiver time in the US for those with dementia or neurodegeneration, or really just anyone living in a long-term care facility, is free. I mean, it's unpaid. So we gotta remember that. And the more we identify and encourage people, the more we're going to be able to move towards scenarios where we can provide kind of funding and ability for people to feel have some compensation for that. So I tell patients and caregivers, know your benefits. So maybe you're in a long-term care facility, but maybe you also have some ability to have someone come on site that might not otherwise be available. Maybe you can get an occupational therapist, a physical therapist, something else to come on site to help with something. Maybe that long-term care facility can arrange for that. So encouraging them to really use what's necessary for them to improve their quality of life. And I tell people it can be overwhelming. Healthcare is overwhelming. There's a million credentials. There's a million different backgrounds. So helping educate them, like, this is the kind of person you're looking for. If I want someone to get like that CBT, let's say I want them to do trauma-focused cognitive behavioral therapy for like a good 12 sessions. So I'm going to tell them, please look for someone with a master's level or more, so like a master's or a PhD or a PsyD, something like that, who has this training, who's trained in cognitive behavioral therapy. So I have to educate people for what to look for. So questions to ask, and these are all going to be available, right? So some of this is just written down so that you guys can kind of have something to come back to. But these are things to ask for family members, because a lot of times we have family members that pick up our patients, our residents, and take them, to appointments. Sometimes we're taking them. You just have to keep in mind, these are all questions that are going to be important. You don't have to obviously answer every single question, but it kind of gives them a sense of like where the variability is. There's a lot of differences, right, between providers. And so knowing what's important and having this written out can just kind of prompt a few questions. Some of this can also just be asked at the front desk, right? It doesn't have to be asked to the provider, but it can be asked to other support staff. But it can really help give a sense of empowerment to whoever's accompanying the patient to the appointment. So more questions for providers. So again, think of the practical stuff. It's not just the medical expertise, but practical things like maybe you can only make it, late afternoon, maybe on weekends. Maybe you really need someone that can do video calls nowadays because you're not going to be leaving your facility for an appointment. These are all things you want to be keeping in mind, and having how to reach them on call, etc. Again, really encouraging caregivers, and I really hammer this in, but write things down, please. Like, you're going to be so overwhelmed with everything you go over in a visit. You got to take notes. Yes, hopefully you're going to receive a little after visit summary, but that's often not going to be exactly the format that's going to help you remember. So definitely take some notes, grab a piece of paper. That'll always be available for you. If you're at home on a video call, perfect, take some notes. Always make sure there's somebody with the patient in the appointment. In our community here, everyone should have somebody with them. Even if they're cognitively intact, it's always a good idea because there's, again, so much information and perspectives different. So for me to see me in general, it's a requirement to have somebody with you to see me. So, that's going to make a big difference. And then kind of some example preparation sheets where you can almost kind of like have things that you can just check things off as you go. Are you taking all the medications? Do you know what all the medications are? A lot of people don't include their supplements. A lot of people don't include over-the-counter stuff. So be comprehensive. Some of our residents might just have stuff family members are bringing them and we don't know. Are your senses all tuned in? Do I need to think about it? So many patients I've had that have had hearing loss forever, and I'm the first one to make them get hearing aids, or glasses, or update their glasses, things like that. Encourage people to just come out and speak honestly with their providers, with us, really give them that space so that they feel comfortable. It can be really hard to acknowledge and accept, decline, both physical and mental decline, so we want to really give that space for them to be able to share that. One thing I do that I don't necessarily, obviously I don't want to throw all the providers under a bus, like this is the way to do it, but think about your strength and how you can, part of our skill as providers is communicating a diagnosis or the treatment plan in terms that are understandable and accessible, right? And so what I found is effective, and this is for me, is since I do a lot of the dementia work and diagnosing, in general, I always walk patients through brain imaging. And that's really something that's resonated with patients and families, because I show them on their brain, and I show them with and without, let's say, Alzheimer's, so that they see the difference. So when they see that themselves, I've never had anyone react other than saying, wow, this is amazing. No one's ever, walked me through this. It's so good to be able to see my brain. And I'm sure, they've had radiology imaging many times, but it can be really impactful and it can be much more memorable for them to understand, wow, this part of my brain is shrinking. Look at that. Like I can point to it. That's just an example. But the example is not to say you need to go over medical imaging. The example is find a way to make it real for the patient. So put it in terms they understand, something you can really point to. So when you're explaining a concept that's difficult, like dementia, it's a really complicated concept. You want to always try to connect that to something that's accessible. Move all along, and a lot of this obviously is for reference for later. Being prepared, asking questions. A lot of patients, I got to really dig. A lot of caregivers and family and friends and everyone. I'm like, okay, come on, ask some questions. And maybe they're shy, maybe they're nervous, maybe they're, I don't want to, I know that you're busy. I don't want. So you've got to give them that space. Here's some examples of questions to ask. I won't go through these individually one by one, but these are just things to help prompt people. And you can kind of just hand these to patients and caregivers and loved ones to basically try to remember them. Oh yeah, I meant to ask this, because that always happens inevitably is, oh, I forgot to ask this during the appointment, and you're stuck answering a long email or a message, and that's not as ideal. So here's an example preparation sheet you can use and also hand out, but this is one focused more on medication, but I really want family and caregivers to be involved with the medications. I don't want to be in a position where I'm just making the decision myself. So I want them to be empowered and also challenge me to minimize medications and make adjustments as necessary. Here's some more questions to ask in terms of the specific on medications. Some of it's practical, some of it's just scientific, but sometimes you're giving a capsule to a patient and they realize, then I find out a month later, like, oh yeah, I've been, opening up the capsule and just dumping it in my tea. And you're like, oh no, like maybe that's not, appropriate. Or it's an extended release tablet and they're breaking it in half. You're like, no, don't do that. there are a lot of practicalities. A lot of different forms drugs come in, and it's super important that they're clear on what to do. So prevention comes up a lot. How do people put it? You can put in the chat, or better yet, since it's my last session, you guys, are so happy with these and you really want to show your support, you can unmute yourself and say something verbally. That would really make my day, and I would just be so happy. But I'm curious from people if you have any examples of what do you tell to someone when they're like, oh my goodness, my mom, dad, grandfather, grandmother, loved one has Alzheimer's. Oh, I'm going to get Alzheimer's. What's a piece of counseling you give? Joanne, I think you're unmuted, but it's not coming through if you're talking. I'm touched by the attempt, though. Anyone else? Or if Joanne, you're working on your microphone, is anybody? I'll accept it if you write it in the chat. But what do you counsel patients or families that are worried about, let's say, their dementia risk? Because I think that's a really common one that comes up. Did they say, oh my goodness, my mom had it, oh, her mom had it, my grandfather had it. Oh man, I'm gonna get dementia. What do you tell people?
So, can you hear me now?
I can hear, yep, now I can hear you.
Okay, basically just say, I have an echo.
I think you might have two different speakers
now,
on.
Now can you hear me?
Yep.
Can you hear me now?
Yes.
Okay, I can't hear me, I can't hear you. I advise them to talk to their doctor, maybe ask to see a specialist, and there are tests out there that you can do. But certainly just because it's in your family doesn't mean you will get it.
Excellent. Anyone else before I add my 2 cents?
So I've kind of dealt with this with my husband's family. They have quite a bit of dementia in their family, and so he worries about it for himself and for his dad. And I just reassure him that if you see changes, you're better off to act on it early than later, because once things are gone, they're gone. But if you aren't in denial of it, then you can do things early that are helpful.
Yeah. No, yeah, my wife tells me I'm in denial all the time. So just what I want to hear. No, I'm just kidding. No, that's correct. And that's obviously good advice to give. I'll also tell you right now, this is something you guys can kind of put in your pocket and tell people that the vast majority of the time, the drivers of that dementia are not like genetic in terms of heritable. So unless your family has had a family tree where people are getting dementia like well before the age of 60, the risk factors are actually zero. And what I mean is we followed millions of people, and when they say, oh my goodness, my grandmother had it, but I almost always, 99% of the time, because it's rare to have genetic Alzheimer's, I'll say, hey, were they in their 80s and 90s? Yes, the answer is yes. Oh yeah, I was at the end of life in their 70s, 80s, 90s. And I say, actually, we followed millions of people. There's no increased risk of your subsequent generation of getting dementia, even if everyone in that generation had it. So just keep that in mind. You can really feel free to sort of counsel people and reassure them, because that's the vast majority. Yes, do I have patients with the Caribbean gene from Puerto Rico? Yes. Do I have patients with the Swedish gene? Yes. Presenilin 1, 2. Yes, there are known genes, but I'm talking, these are rare genes. And these are very obvious family trees, very obvious clusters that are pretty well known. So just keep that in mind. It's something that we can do that automatically will have an impact. Hey, oh my goodness, nope, you don't have to worry about dementia if it's late onset. Then what you need to worry about is all the preventable stuff, right? Taking care of yourself, being healthy, all those things. That's what will actually help you, keeping your senses sharp. So there's a bit of counseling that you can kind of take home right away and start using. Thank you so much, Joanne. And was that Andy? Thank you so much for mentioning that. You guys made my day. You guys get extra credit. So again, these are those little bits of counseling that can really come in handy and really have an impact on people. These kinds of questions are always going to come up. You know, hey, my loved one had experienced trauma when they were younger, and had this adverse childhood experience, and I did too. Oh my goodness, am I gonna, end up, with memory loss and that kind of thing? These are things that can come up, and we've got to be ready to provide reassurance. Will I continue to work, to drive? Number one hardest conversation I have by far with patients is the no longer driving conversation. So really being informed, and really reassuring them. That doesn't mean you're going to be stuck. You're still going to have independence, and focusing on those other independent methods for them. Let's run through last few slides. I know we're almost out of time. So discussing sensitive topics, still super important to ask about things that might be uncomfortable, because these are things that affect us at all ages. So sexual function, incontinence. You can use other resources. If it's really hard for them, it's okay. Have them, give them some videos, some other online resources, whatever it might be, some things you can print out. But we want to be clear that all of these are topics that we care about. Managing difficulty with communication with some providers. So obviously we'll all get caregivers. I've had caregivers that, because they're so upset for understandable reasons, right? It can be really challenging to communicate with them. And so that empathy, really coming back to validating, repeating their concerns back to them, making sure they feel listened to and heard, that's going to help de-escalate and really help, hey, I'm here to take care of your loved one. I know you're obviously very committed to helping take care of them. This is why you're feeling the way you are. And so it can be challenging communicating sometimes when people are emotional, but it's going to come up, it's going to happen, and we have to do that. So we want to be ready. And it's only natural. If you're handing out or talking about a loved one who's having a really, really hard time, they might come in and see, well, mom was walking a week ago, why is she stuck in bed? And then, it might get escalated. We want to, really be reassuring and spend time listening to that person, help them along. And Marcy just posted the recordings from the website. And please make sure to complete your evaluation before you sign off. It's in the chat link. Last couple slides, just writing down as much as you can. I have people record our visits sometimes, or record things. I'll say, hey, we should record this, or they'll even think of it so that they will remember it. Really writing down, like, as specifically as possible what's going on for them in terms of what's like Alzheimer's disease versus what other diagnosis. We're out of time, so I know I was trying to get people to share some stories, but I wanted to think about, and you guys can think about this, but some success stories where you were able to give some information or some resources that increase their effectiveness at taking care of their loved one. And of course, I'm going to stick around for a few minutes. So if anyone wants to share a success story, please do. But please fill out your survey. Please know that you can access these talks online, so you can print out some of these slides for resources later. And this is the 10th session, so special thank you to all the staff at Mountain Pacific who really made this happen, made this possible, had the idea, and it really provided incredible support to really make my job pretty easy. So thank you to everyone, and thanks for everyone for kind of attending and participating. Remember, we'll be kicking off a new series focused on substance use by my good friend and colleague, Dr. Seiss, and keep look out for announcements. It'll likely start in late April. And I'll stick around for a couple minutes. So if anyone has any comments, any questions, please feel free.
I just wanted to say thank you so much, Dr. Gomi. These have been really excellent, and we're just happy to have you on board, and just luckily we have them all recorded. So if you missed one, just check out our website. And that VA tool that you showed earlier is actually under the February, I think 24th session. So that's on our website as well. That was a great resource.
Wonderful. Thank you. Thank you. Yeah. And thank you for all your support. And we can give Alona a hard time for not being here for my last one. It's
I
messed up a
know,
little.
right?
This is being recorded, right?
It
Good.
is.
So I'm mad at you, Alona. Has completion of surveys and everything afterward been okay? So if there's anything I can do to help promote their completion, let me know. In terms of information you guys need.
Okay. Keep you posted.
Anybody else? Here's your chance. You're welcome, Casey. Talk to you soon. Okay, and I guess, forward any questions that come later to me. Feel free to forward.
Thank you.
Will do.
All right, everyone. See you again soon.
And have a great rest of the day, everyone.